Great. Well, welcome everybody to one of the continuing webinars, continuing education offerings of the United States Brain Injury Alliance. My name is Geoff Lauer, and I have the honor of serving as chair of USBIA this year and last year. USBIA has a mission to engage the community in preventing brain injury and improving lives. And we offer a number of services that support our state organizations, as well as information for people with brain injury and their families and professionals. So again, from around the country, we welcome you. Have the great good fortune today to introduce Dr. Jerry Gioia from the, Jerry is the Division Chief of Neuropsychology, as well as a director of the Safe Concussion Outcome and Recovery and Education Program, known as SCORE, at the Children's National Health System. He's a professor at GW School of Medicine, directs the Neurobehavioral Core Research Laboratories at Children's National and the Translational Science Institute, as well as the Intellectual and Developmental Disabilities Research Center. He doesn't do much. Yeah, I'm kidding, of course. He treats people with brain injury, as well as families, with dual areas of interest in disorders involving executive functions, and he has a special focus on pediatric concussion, mild traumatic brain injury. He has been the principal investigator of numerous multi-site Centers for Disease Control and Prevention funded research studies on pediatric mild traumatic brain injury, with a focus on the development of methods and tools for the evaluation of exec functions and post-concussion neuropsychological functioning. So Jerry, thank you so much for agreeing to come on deck with us today.
My pleasure, Jeff. Great to be here.
So what we'll do today is we're going to have a casual conversation with Dr. Gioia, and I would really encourage all of you as we go through this, or at any time you'd like to add a question in the chat if there's an area of interest that you'd like to see addressed over the scope of what we're talking about. The title, by the way, of what we are talking about today is The New Age of Concussion, Refining Diagnosis and Treatment. And so we'll be talking about components of mild traumatic brain injury in kids, perhaps in adults, around diagnosis and treatment. So if you do have a question, you're certainly welcome to add it, and we'll get to that here in a bit. So Jerry, what's new? I mean, well, even before that, let me just, first of all, throw out this mea culpa. Many of us over the last year, as we've been working in the area of pediatric concussion, have found that it's taken kind of a step back in prominence as a result of the all hands on deck issues with COVID-19. But it's now August, and things are ramping up for another I don't know how much more, but somewhat more normal school year. And concussion is, I think, flowing back into awareness, at least in my neck of the woods, very heavily. So what is new in the field of concussion diagnosis over the past year or so?
Well, first of all, there's lots that's happening. I'm not sure I would necessarily say it was over the last year, but
sure.
One of the things that the accumulation of our research understanding over really probably the last 5 to 6 years is really starting to look at concussions as not a singular element, or mild traumatic brain injury is not a singular element, but that there are different manifestations or subtypes of these injuries. Now, let me also qualify that by saying that when we talk about these subtypes, we often talk about those individuals who have a bit more of a protracted or prolonged recovery, and we'll get into the whole issue of treatment, because these subtypes do is they allow us now to look at the specific areas of treatment that can help a person recover. We've gone from, and this is really over the last, I'd say 5 to 10 years now, from a more passive kind of rest model of recovery to a much more active rehabilitation model. And so, with active rehabilitation, with better definition and specification of the injury, and with more specific treatments, it really allows us now to do some things in far, more patient-specific ways than just sort of a generic kind of sit home and rest.
That makes sense. Let's go down that rabbit hole a little farther in terms of the subtypes of concussion.
Yeah.
Can you give us a little feel for how many, what's distinguishing them? Are they image-based? Are they clinically based? Are they part of the brain that's injured based? How is that being teased out?
Yeah, well, they really are clinically based, and they are to some extent sort of symptom cluster based. So we talk about kind of 5 more specific subtypes, one being sort of a headache subtype, and that's where the person really has this prolonged, or more specific manifestation of headaches. Now we know that in general, headaches are sort of the number one symptom. We see it in 80 to 90+% of individuals with this injury. We sort of break up now kind of the physical symptom cluster into the headache subgroup. We've got the vestibular subgroup, that is those individuals now where really the body's gyroscope is really thrown off. The ability to sort of maintain our balance and really move in ways that are more automatic is disrupted. We then have probably the most recent subtype is this emerging ocular motor, where really visual scanning, eye movement seems to be a specific problem for individuals. And then we can look at the cognitive kinds of difficulties, and that of course subsumes a number of things, attention and kind of being able to hold things online in short-term or working memory, and being able to sort of process things in more kind of organized ways. That would be a subtype. And then the last one is really the affective or emotional subtype of mood, anxiety kinds of factors. Now, what's important, as most people in the field recognize, is that typically we don't see an individual with only a single subtype. I mean, usually there's a mixture of factors here. You might have somebody with a headache cluster and a vestibular cluster, or someone with more of that mood anxiety element together with a cognitive piece. There are 2 other conditions, though, that, and we had a whole subgroup that worked on this together. In fact, we're still kind of working on it now. And sleep is a big factor. But we sort of held off on saying it was a subtype, only because most people have kind of the sleep fatigue element that goes into this injury at a greater or lesser extent. So it felt like it was a more general manifestation, but nevertheless one that needed to be recognized because it potentially also needed to be treated. And then the second of the more general kind of areas was kind of a cervical spinal element. Not infrequently when one is hit, the head and moves back and forth on the neck, and you get a strain, of the cervical spine. That can also contribute to sending signals up that affect headaches. Can also have other kinds of potential balance vestibular kind of elements here. So we kind of look at the 5 core subtypes, and then with that the kind of sleep energy element and the cervical spinal. This really stemmed from a meeting that was held in Pittsburgh in 2015, where the real focus of that meeting was, we no longer believe that just a simple passive rest model is what we should be doing in helping people recover from this injury. But at the same time, we need to be focusing our treatment on the specific areas that a person needs. And so how do we then begin to characterize or define or clinically assess these things? And that's when a group of really 35 experts got together, and we all sort of brainstormed what we thought were the likely kind of clinical profiles. And then from that meeting forward, we had a smaller group of us that then went in and further defined those subtypes, actually looked at the literature and had some pretty good validation of that. And then have begun to sort of develop tools and measures that can help to define those things.
So that's an interesting piece. I'm sure, I believe on today we have some folks who are in concussion clinics around the country. And those tools and models, are those in the public domain yet?
Well, we have 3 papers that were written, and we can certainly make those available, that define the sort of the whole subtyping model. Well, first of all, describes the that initial conference that we held in Pittsburgh,
Yes.
that UPM, it was held at UPMC. And then from that, the evidence-based review that looked at the definition of those subtypes. And then from that, a paper that looked at how do our current symptom scales perform in identifying these subtypes. And now we've actually got a tool we're developing called the concussion symptom subtype inventory, or the CSSI,
Yes.
that really kind of looks at those 7 areas with greater definition.
Okay, I do have a quick question I'm just going to put up there. The question is, you mentioned headaches. Are there any new treatments or any unique treatments that you've seen emerge for post-concussive headache?
Well, let me just say, not on the medication side.
Okay.
And that oftentimes is what we want to know is, first of all, these headaches have a mimicking element of a migrainous type. The cluster tends to be, the headache, some light noise sensitivity, some nausea. I mean, those are the 4 kind of core symptoms that go along with it that have a very similar sort of migraine mimicking kind of manifestation. And in fact, as you might imagine, for those individuals that either have their own history of a migraine headache or a family history of that, we tend to see those kinds of symptoms become a bit more prominent and potentially more prolonged in their presence. And so the treatments for that really are kind of the standard treatments that we use with migraine headaches. Yes, there are medications that can potentially help, but then we also really focus on hydration, good sleep, and then getting exercise built into the program, but doing it in very metered ways that doesn't obviously exacerbate the headache.
Right. Thank you. So that is helpful. So then here's a clarification question. Are these clusters related to, if you will, more durable symptoms, persistent post-concussion symptoms lasting greater than 4 to 6 weeks, or are these clusters, assigned earlier?
Yeah, well, that's a great question. And in fact, they really started really with that sort of persistent post-concussive kind of time frame. And again, that was, look, my lights turned off here. So turn on my lights. So the original definition really started with kind of those individuals that had the persisting kind of patterns. What we're really interested in doing, and in a study that we're doing right now, is looking earlier in the post-injury time frame to see, can we see when those things begin to emerge? How early can we see these things emerge? And so we'll have a better definition of that as we move along. But most of us that are treating this, the injury, we kind of look at all those areas pretty much from the time of the injury on anyways. It's just whether one sort of persists and the other really resolves. That's something we don't quite know the trajectory of yet.
Thank you. So another question that pops up is this issue distinction between MTBI, mild traumatic brain injury? And is there a redefinition ever of persistent post-concussion then becoming, now it's no longer mild, it's now, we can call this a moderate brain injury?
Yeah, well, so this is highlighting an important issue that I think we all experience in the traumatic brain injury field, which is that the mild, moderate, severe, distinction is very muddy. And I often say to people, we call this mild traumatic brain injury, but if you're experiencing this for any period of time, it's not mild in its effect on your life. And so that's kind of a term that is not only not helpful, but probably to some extent a little bit insulting as well.
I would agree.
I don't know, though, that adding moderate to it helps.
Right.
And so, and the other thing too is many of us are moving away from what was termed post-concussion syndrome and really calling it persisting post-concussion symptoms, or PPCS for that term. And again, with the view that this can be treatable, and this is something that we can really address, and the syndrome element seems to have this finality to it or something. I don't know. I mean, it probably means different things to different people, but to me, it's not particularly helpful. I'd really like to focus in on where's the issue that's affecting your life and what do we do about ameliorating it.
Right. What's the difference in these subtypes, if any, between children, pediatric population, and adults? Is this applicable across both populations?
Yeah, and so the paper that we did, that evidence-based review, actually looked at both the literature in children and adolescents and then in adults, and pretty much found the same support for the subtyping, regardless of that age factor.
So is there a difference in brain injury, do you think, with kids versus adults in terms of the early manifestations and or the more persistent symptoms? Are kids more at risk? Are they differentially at risk depending on their developmental stages? Is there something to pay attention to between a typical 5-year-old versus a 12-year-old versus a 27-year-old?
Yeah, well, if we had good data, I could answer that question a little bit better.
Okay.
As we've learned, the preponderance of data that's available historically have been male, adolescent, or college athletes that play a contact sport.
Right.
And so when I have a family with an 8-year-old girl that comes in here, I say, well, we're going to do our best to understand kind of, your particular manifestation, but that data is not necessarily the best. The one study that I think has probably been the best one, but it doesn't go into the adult years, is the Canadian 5P study, in which they studied 3,000 kids, boys and girls, from 5 all the way through 18. Now, what they showed is that the period of adolescence seemed to have its higher risk for a more prolonged recovery relative to younger kids. And then when we look at, again, a different data set now going into the athlete world, what we see is that adolescents relative to college athletes and professional athletes, the adolescents still are the ones that tend to have the longer recovery than those other populations. But again, there's a little bit of an apples to oranges problem in our comparisons right now. But the thought is that there's something potentially unique about that adolescent developmental period, whether it's biological, whether it's risk factor and the type of injury that may be contributing to a different recovery trajectory. And then there's differences between males and females as well. Again, we don't entirely understand the reasons, but it seems that as a group, females take a little bit longer to recover than males. And the 5P study showed that as well. It's my belief that there probably is a combination of both biological factors as well as other sort of risk situations and the types of injuries that different people have that result in different outcomes of these types.
So then there was a question that came up. I was talking about, or I asked about the difference between kids and adults, but what about elders? Any sense, do you see in your clinic folks who are, in their 60s and 70s, 80s?
So I do not, as a pediatric neuropsychologist.
Right.
Probably the oldest that I see is in their 30s, and those are the professional athletes that I take care of.
Sure.
My own clinic is pretty much college age and below. But having said that, and again, if we think about it, preschoolers and the elderly have not necessarily been the focus of
Right.
our research,
Right.
let alone school age, non-athletes as well. But I would predict that the elderly would have a higher risk, of a more challenged outcome, in part because biologically probably don't have the same compensatory mechanisms, and potentially, we think about the mechanisms here, falls and other kinds of injuries in which there may be less capacity to protect oneself, and so the blow may be of a different nature. But to be honest with you, there's not a whole lot of literature that I'm aware of that specifies that all that much.
Sure, that makes sense. That was a specific question that came in.
Yeah.
Specific question, to go back to subtypes. Is there, in your understanding, any correlation between the site of impact and the subtype of concussion?
That hasn't been the at this point, no.
Okay.
Now, I can give you my clinical viewpoint that when people hit the back of their head, that as they fall backwards and hit, there may be a different manifestation. At least I've seen a much higher level of fatigue and some balance and ocular motor issues as we think about what's back there, the cerebellum, the occipital lobe. But that's certainly not everyone, and it's interesting, Geoff. We are about to embark on a big NIH, a multi-site NIH study in which we will be characterizing the nature of these injuries in a very, very sort of comprehensive way, not only looking at the mechanism of injury, but also gathering a whole set of biological elements, such as brain scans, blood biomarkers, looking at the autonomic system, looking at their cognitive and their affective functioning. And so we will be following, and it's going to start in early adolescence, age 11 and moving forward, to really better understand what are the things that might predict. Is there something about location? Is there something about location that relates to the actual changes, in brain function?
Right.
Are there certain kinds of biomarkers released, by certain kinds of injury types? All these things we'll have a much better handle on than we currently do. And it's going to be in a very large group. We have 6 different sites around the country that'll be gathering data on this. So from that, the purpose of the study is really to predict,
right?
Can we have a better prediction now of whether you're going to take longer to recover or not, based on those both biological, sociodemographic, cognitive kind of and affective components.
Right. So biomarkers, are there any consistent quality diagnostic blood or saliva biomarkers that you use or that you feel can be used right now?
Yeah, so I'm not the biomarker expert, but yes, there in our proposal, we have a battery of factors that we're getting from the blood, and Jeff Bazarian from the University of Rochester is the expert that is really in charge and actually working with some of our colleagues from NIH to really highlight. So there are some blood biomarkers that have been shown to be related to outcomes. And what we're interested in now is, can we specify this beyond just the group to say, the group of individuals with this biomarker show a different outcome than this group, without that particular manifestation of the biomarker. What we're interested in doing is really coming down to a clinical algorithm that would say, if you have this particular factor in your blood, if your autonomic system is impaired in this way, if your cognitive functioning is, these collection of factors may result in these different kinds of outcomes. And we're also going to be looking at, again, that subtyping element as well.
Right.
So it'll be really exciting to get it down to a little bit more of the individual level than just simply the group level.
Makes sense. Thank you. So there's been there's a couple of perhaps left field questions that I've been pondering since we knew you were coming on. One is, when I look at what the Department of Defense is focusing on for their algorithms for post-concussive diagnosis, they have a neuroendocrine component to a range of different symptoms. And it raised the question for me, would that be germane to kids? Could or does, in your understanding, concussion potentially, or brain injury, mild traumatic brain injury, lead to neuroendocrine changes that might be part of that, 5+2 matrix?
Well, yeah, I mean, it certainly could underlie, and again, it's not been looked at really for kids.
Right.
It was. Let me also say that, at least in the study that we're doing with this persistent post-concussive symptom study, it was. We're not necessarily focusing in on the neuroendocrine factors.
Yeah.
And I have to sort of go with my colleagues, who really are looking at some of the biological factors here. They're looking in different directions. But having said that, I think there is at least a small percentage of individuals where there are some effects on the neuroendocrine system. Now, whether it's predictive of one thing or another, I don't know, but certainly clinically, there seem to be some individuals where we find that there may be some, like, even alteration in their growth patterns. But that's not an area that's been highly studied in mild traumatic brain injury. It certainly has been in more severe, and certainly with kids as well.
Okay, thank you. Just curious about that. So the other piece, one of the other ones that has popped up on the radar screen over the last 6 months is some studies that show a dose-response relationship, the relationship between the number of concussions that a kid and or adult gets and the advent of dementia, the relationship between the number of concussions and early onset or earlier onset dementia as an adult. Any thoughts on that? Do you have a feeling that, when parents are trying to calculate risk versus return in terms of what the benefits of playing in sports are, and being part of the team and being part of an organized, structured kind of relationship in school versus the third, fourth, or more concussion, has that fallen into the matrix of deciding with you in your clinic?
Yeah, well, certainly it does. But let me just say that the data that you're describing,
yeah,
is what I would call hypothesis generating,
okay,
rather than hypothesis confirming. What I mean by that is that data really is of a retrospective nature. So individuals who had some, relatively difficult outcomes, then there was a retrospective look at what might be the factors that contributed to that. And one of the elements was, their injury profile. What we really need is, so that's a very select sample that's kind of going back. Yeah.
Mm.
What we really need is a prospective study going forward to really understand what is that risk factor. I mean, I see, a fairly large number of kids, and they have varying degrees of, injury history. Some with this is their first and only, and others where it's maybe a third or a fourth. It's difficult again because of the, let me just say that study that you described, as I say, is hypothesis generating, meaning it gives us questions that we should be moving forward to study. But what it also alerts the clinician to is, what is this risk history of this youngster? And we look at a number of factors that tell us that, that suggest that maybe the brain is becoming more vulnerable to this injury, and we want to really sit this kid out of a contact or risk situation. And so when we look at the number of injuries that a youngster takes, are they becoming more frequent? That is sort of a shorter kind of interval in between them. Do we see that it's taking longer and longer to recover? That is, the brain is not really as resilient. Is it seeming that those injuries seem to be occurring with lighter forces to the head? So now there's just a much quicker kind of injury response. When we get those kinds of elements that come together, then that's a very worrisome pattern. Now, again, we don't know what that means for the long term because we just haven't seen or followed those kinds of kids prospectively. But it's enough of a set of kind of red flags that tell us that this youngster really needs to stay away from those contact risk situations, whether it's forever or for a good period of time. But they need to be followed carefully, and so we follow them cognitively and emotionally and physically, and we want to know, are they kind of rebounding better now after, say, a year or two away from that?
Okay.
Now, having said all that, I often tell the families, I'm not suggesting you don't do a sport or an exercise that's non-contact. In fact, that's very good for you.
Yeah.
But I would suggest you not do it in a way that is, risk, high risk so the simple answer is, as clinicians, we can sort of look at that individual case and some of the risk factors and give some guidance, but we really don't have a lot of information as to say, are you going to be in that high risk category of later dementia or, more significant like neurocognitive problems.
Got it. So the time, that duration to return to play with a higher risk of contact and concussion is kind of case by case. I heard you say something like a couple of years.
Yeah, it would be a case by case kind of thing. Yeah, I mean, and we really want to be monitoring that person's function very, very closely to make sure that they are not declining in their overall function.
Thank you. There is, we're going to go into the weeds here with a very precise clinical question. I'm going to come back up and ask a general question about this major treatment shift from rest to active rehab in a second.
Yeah.
So one of the questions is, do you have a go-to battery of tests when diagnosing mild TBI? For example, cognitive assessment, NEPSI-2, etc.
Yeah, so we do have a general set of measures that we look at. And let me first say that in truly diagnosing the injury, we developed something called the Acute Concussion Evaluation, or the ACE, many years ago. It's part of the CDC's healthcare provider toolkit. And what it was a way to sort of capture in a more standardized way that the nature of the injury and its particular characteristics, whether there was loss of consciousness, amnesias, seizures, that sort of thing, but also the type of mechanism, whether it was sport related, whether it was falls, whether it was motor vehicle, that kind of thing. But then also, were there some early signs that were seen? Was the person now, really having difficulties remembering on the spot what they were doing? Were there balance problems? Were they having, challenges with sort of affective regulation? And then we get into the whole symptom kind of assessment. And then along with that, we look at kind of risk factors for potentially prolonged recovery. And so the ACE was built to kind of standardize that process. Within the cognitive domain, because we know that, certainly, cognition can be impaired. The area that we, or not the area, well, the functional areas that we assess are speed of sort of processing and speed of performance. And so any measures that you can use that have a good standardized speed factor. And so, it sounded like this was a psychologist or a neuropsychologist asking
Right.
a question. Certainly the NEPSI or the WISC or the WACE, those kinds of things have these, processing speed elements. And then we also want to then look at attention and sort of, working memory. That is, how well are you able to sort of keep your focus and then hold on to information in that short term there, because those areas seem to also be potentially affected. That would be the narrow battery that I would consider. And again, with that, of course, a good symptom questionnaire, whether it's part of the ACE or we developed a few other measures as well. And then the other piece is, assessing someone's balance. And so a good screening tool is the balance error scoring system that my colleague Kevin Guskowitz put together at North Carolina, that really, has a double stance, a single leg stance, and a tandem stance, with eyes shut on a firm ground, or we also have a foam pad we put them on. And there's a way to score the errors to see kind of how well are they able to navigate that. And then our Pittsburgh colleagues have put together a nice tool to look at the ocular motor kinds of issues. So the BOMS, which is the vestibular ocular motor screening measure. And so we look at those functional domains, visual, ocular, and motor. We look at the vestibular ocular motor. We look at the balance. We look at cognition. We look at symptoms. We get a good definition of the nature of the injury itself. And that helps now to characterize that injury. And from that point, it sort of leads into our treatment recommendations, which we can get to in a minute, unless you have some follow-ups on the battery.
Thank you. Thank you very much. So you really appreciate you going into the subtypes of concussion around diagnosis. But one of the major changes I know you mentioned in reacting to concussion is this rest with its perhaps most extreme dimension of cocooning to now active rehab. Could you tell us about that transition and how we now conceptualize the autonomic nervous system and the heart-brain relationship in normal and concussed states?
Yeah, so the two people that I really credit for really moving this forward in 2009, 2010 are Isabelle Gagnon, who's a physical therapist at Montreal Children's, and John Letty and Barry Willer at the University of Buffalo. And it's kind of interesting. They both independently were interested in this question. Isabel, as a physical therapist, has worked with brain injury for many years. And she said, why is it that kids with more severe TBI, we want to start to activate and start to move them a little bit, but kids with, the mild TBI, we tend to kind of sit them down and rest them. What's that about? But they also had a clinic where they were getting individuals coming back 3, 4, 5, 6, 7, 8 weeks after their injury and still very symptomatic.
Right.
And she said, shouldn't we be doing some different things? And so she put in place then this aerobic activation protocol. And her first paper was really just looking to see, is there some type of a reasonable effect? And it was a fairly gross, assessment of that, but they demonstrated that maybe there was some benefit in the reduction of certainly the symptom profile. Independently, John and Barry at University of Buffalo were very interested then in looking at heart rate, at looking at the autonomic system. First of all, they were interested in can they look at a physiological versus what they call a psychological sort of pattern? But within that model, they also were engaging individuals with, with graded exercise and what they called the sub-symptom threshold model, which is, let me work somebody out in a non-jarring, maybe on a treadmill, maybe on a bike. They have their treadmill test, of course. But we want to see, by increasing that heart rate, what does that do to symptom provocation? Between the two of them, they both kind of realized, again, independently, and I remember reading both papers, and I said to John, "Do you know Isabel?" And I said, "Isabel, do you know John?" He said, "No, we never met each other." So we actually had a phone call once. I said, "Hey, guys, you really need to meet each other. You're doing some of the really great work here." And as a clinician here as well, what we were noticing, and especially with athletes, but take any kid, you sit them down and do nothing, and you're making them miserable. I mean, they are not happy campers. And the question that we were asked sort of pragmatically is, well, what can they do that's still safe? And so those are some of the questions that are being asked. And then we started to see the protocols come about. And Isabel actually sent us this very nice log that we could use. And instead of actually taking heart rate, what we did is we taught kids how to monitor their symptoms in a way that would start to increase their activity slowly using this chart that is actually an exertional chart. And it's a neat little stair-step model of somebody working out harder, and harder. And we taught them how to systematically increase their activity level, while again, remaining sub-symptom threshold without, in other words, blowing their symptoms up.
Right.
And so between, John's work and Isabel's work, many people are starting to do this. And we actually trained our physical therapy groups locally to do this. And kids loved it. It was a really important area for, and not only kids love it, but more and more data was showing the benefits of this. And this actually was one of the elements that I know UPMC was very active in working on, and was a part of that 2015 active rehab meeting, which is that we've all seen the benefits of some of this exercise. Are there other active rehabilitation modalities that we should be thinking about as well? So it is an important element here. Now, I will say that both John Leddy and Isabel started out their protocols with individuals that had the persisting post-concussive symptoms. John started to say, well, I wonder how early we could start to introduce this. And so they've actually started with people 3, 4, 5 days post-injury, and shown that for most people, it doesn't have deleterious effects, and it can be beneficial. So we actually, at the end of the first week of an injury, start to activate kids more and more. And again, we have generally good findings with that.
Thank you. Interesting. So that's such a transition. That's so good. USA Football. I see that you are now on the USA Football Advisory Committee.
Right.
Are there still, what's the word? Is there still movement at that level to change the nature of the sport?
Absolutely. The only reason I'm on it.
Good deal. Tell us what you think is the probable next shift.
Yeah. So there's something called the American Development Model that has been applied to a variety of different sports. And it's been applied for a couple of reasons. One is what they call the athlete development process, where, sports for life, this is a healthy, important thing for us all to keep ourselves exercising. And if you can engage in a sport that, you really like throughout your lifetime, that has important health benefits. And so soccer, tennis, hockey, all adopted these models where they looked at the sport for younger kids and said, what's the most developmentally appropriate way to introduce somebody into the game for 2 reasons: fun and for injury prevention. Or it's probably more than 2 reasons, but for my purpose, it's those 2 main reasons. We want the sport to be fun, so that's not over kids' head. If you think about the tennis net being up at your eye level and you have a big tennis racket, you're never going to be able to hit the ball over there. What we looked at was hockey. The size of the hockey rink was so huge for kids, and only the fast kids that had bigger brothers that knew how to skate were the ones with the puck. That wasn't actually a satisfying thing for the kids. Well, and so the question was, how do we start to look at what was then called the football development model? What is an appropriate way to start somebody in the game that is developmentally, synchronous with their situation, themselves physically, cognitively, emotionally. And then, from an injury perspective, what if we started to look at the game and change sort of the contact requirements? And so from the football development model process, we put out a set of recommendations just this past year as to how you enter somebody into the sport, different trajectories. Some kids may just want to play flag football and not do contact. That's great. Some kids may want to start with flag, sort of the non-contact, and move into what's called the modified game, in which now there are different sort of rules around, contact, and then, potentially move into the full game. But again, they could stop at the modified game if they want. And then taking some of these sort of outdated and dangerous practice elements out of the game, something called bull in the ring and those kinds of things, making sure that kids are not practicing 2 days in a row with contact when they are in the contact game, limiting the number of games in a week because there was sort of no guidance around that. So the whole idea was to manage not only the introduction into the game, starting with no contact, but then bringing somebody up through the game with a much more appropriate introduction of the contact. Now, as part of this process, from my perspective, we're not done yet. I happen to think that we need to take development even one step further, which is at the individual level. I often tell people I was actually this size when I was in 7th grade. I actually grew very quickly, and my development was more in terms of my coordination and speed and that sort of thing. I had a brother that was half my size until he was in like 9th grade, but he wanted to play football like his older brother did, and that wouldn't have been a good thing for him. Fortunately, he sat the bench, but the other fortunate thing is he didn't quit. I mean, I don't know why he didn't quit, because he didn't play at all. Well, what if we found ways to enter kids into these games, and not just football, but take any sport that's developmentally appropriate to their physical, to their cognitive, to their social, to their emotional sort of status, in a way that really helps them. And we actually not only build the games, but we teach our coaches how to sort of do that. And I use the principle, where you don't go up to a 2nd grader and give them a Harry Potter book and say, read it. In other words, you don't give them the fully formed product at a young age. We give them the developmentally appropriate type of reading material, and we teach them along the way. And that's the exact thing we should be doing in football, in rugby and ice hockey and soccer. And, you go down the list here, in cheerleading, anything that brings risk to kids' heads, we need to think much more developmentally. And we've got to start kind of break some of the rules that were there just because they were there. So that's part of my role on the USA football. And I will say they're very receptive to that. They're really taking on much more of a developmental kind of safety model. And that's why I'm with them.
Yeah, that's literally a game changer in so many different ways. Thank you. I did not expect that broad level of commitment from USA Football, or that's awesome. So
well, it's interesting. Let me just say, their head of coaching, their director of coaching, is a former teacher, and so he totally gets it. In fact, in many ways, our best coaches are our teachers, because they know that there are differing levels that kids come in at, and you've got to take them where they are and sort of help bring them along.
Thank you. So there's one real specific question here, and then I've got one kind of final wrap-up question. We have a gentleman who asked me to read this verbatim, and I'll do my best, that he had a first TBI at age 2, and then a second TBI in many years later. The question is there, do you have a sense of the recovery and prognosis at age 2 versus at age 68 years old, with specific thinking about attention and mood? Any sense of what the difference is between being a very, very young human and perhaps a 68-year-old human in terms of recovery?
Yeah, well, let me just say, depending on the nature of that injury at age 2,
right?
I mean, we know that certainly, toddlers, preschoolers that have more severe traumatic brain injuries do not do well in their outcome. I mean, it's a very, sort of tender age of brain development, that we know that the heart, if there's literally hardware damage, in a more severe TBI, that is very difficult to recover from. It's nothing is 100% obviously on this.
Right.
But if it's more of a mild TBI or concussion or whatever, one would argue that there is certainly much greater potential of that being not having long-term consequences. But again, it really depends on that individual and what the nature of that injury was. Because as we know, a TBI is not a TBI is not a TBI. And all of us are different in how we might manifest that. But let me just say the other piece, which we said earlier, we have so little information, certainly on mild TBI in preschoolers. That is a big gap that when we did the CDC review a few years ago, we sort of acknowledged that the guidelines that we're giving right now are not based on any data of preschoolers. And so how it applies to preschoolers, we're not quite sure. Again, getting at to the 68 question, that age, again, the brain also has some of its own challenges, potentially. I mean, many 68-year-olds who are perfectly healthy and,
right,
if you have a concussion, may have a reasonably good recovery, but it really depends on the nature of that person and that type of injury as to what the manifestations are. Each certainly have their risks, but without a little bit more specifics on the individual, it'd be difficult to make too broad a generalization or a generalizing statement.
Got it. All right. So you just told us earlier that there is a really, sounds very interesting to me, large scale, multi-site, NIH funded study coming up.
Yeah.
And it's a 5-year project?
5-year, yeah.
So in 7 years, if you were going to prognosticate, not just based on this project, but based on where you see the research and the focus going, what might you think we would hopefully have at the end of that time period?
Well, my hope is that in 7 years, we will have information that any healthcare provider that has a patient that comes in with a suspected injury, concussion, mild TBI, would be able, A, to diagnose it, fairly quickly. B, would be able to kind of know and have available to them the panel of tests, what we call the definition of your endophenotype. That would then allow us some information as to whether you're likely to make a more typical recovery or whether you're likely to have a more challenged recovery. And then with that come the tools that would begin to define and specify those areas of treatment. And that hopefully then we would be able to put those treatments in place sooner rather than later, because we've got greater specification of your, not only kind of what trajectory you're on, but the specifics of where you may need some help. Now, I believe that everyone needs to be, whether you're going to have that good recovery or the slower recovery, needs to be doing what I call the recovery promoting activities of good sleep, some good, exercise, stress management, good hydration and eating, that sort of thing. But again, my hope is that in 7 years, we will have that combination of biological and neuropsychological factors that will tell us if you are more likely to take a more challenged route that allows us to treat that much more effectively and much more early.
Terrific. Thank you. The participants who will be entering those studies, I assume, are consistent across sites. What kind of criteria will folks have to be able to come in and be part of that study population?
Yeah, so you need to be 11 to 18 years of age and be within 4 weeks of your injury. The earlier the better, but we'll take people out to 4 weeks. And we're working around braces and other kinds of things because we're putting in kids in MRIs, and that's always a challenge. But that's basically it. I mean, there's some specificity in terms of somebody that might have a more active, severe psychiatric issue or developmentally would not understand how to do the measures. So there's some, exclusion criteria, but that's obviously going to be a small number of people.
Right.
So it's a fairly broad sample, boys and girls with those criteria.
And which are the sites are located where?
Yeah, so we have here at Children's National, we have the University of Rochester, we have Wake Forest, we have UT, University of Texas Southwestern, we have UCLA, and then University of Washington or Seattle Children's.
And about how many do you think your total sample size will be?
Oh, well, we're going to have, we have 2 groups. So one is what we call the initial discovery cohort, which is about 650, and then another roughly 650 in the validation cohort.
Thank you. Thank you. Well, yeah. So thank you so much. We're coming up on the top of the hour. Jerry, this ripped right by for me.
Yeah.
I'm so appreciative you taking time out of your day. We will be posting this webinar up on the USBIA website as we do. I want to also alert you that we have our next webinar on November 10th, also at 2 p.m. Eastern time. And Liam Donovan, who is the Criminal Justice Coordinator with the Brain Injury Alliance of Colorado, will be talking about supporting people with brain injury in a criminal justice setting. But so please stay tuned for that. Jerry, this emerging field of mild but not so mild TBI is one that is fascinating. It's got repercussions that travel right now into the world of COVID and neurological recovery and all these different components, but really appreciate your work, really appreciate your advocacy, and thank you for being with us.
Oh, my pleasure. And thank you for the opportunity, and thanks for everybody's participation as well.
Yep. All right. Well, have a great day, you guys. Bye-bye.
Okay. Bye-bye now.